The following podcast is part of a certified educational activity titled The Innovation Intersection in B-Cell Cancers, Navigating Choices with Modern Targeted Strategies, Cellular Therapy, and HCT. Access the entire activity and complete the post-test at peerview.com/FFD860. Downloadable slides and practice aids are also available.
Hello, everybody, and welcome. I know many of you are still getting lunch, but we do need to stay on time because there are other sessions that start following this one today. So I'd like to welcome you guys today to the Innovation Intersection in B-Cell Cancers. My name is Nirav Shah. I'm an associate professor from the Medical College of Wisconsin. I'm here with my friend and colleague, Krish Patel, from the Sarah Cannon Network. And with that, I'm just going to give a quick introduction. We're going to be focusing on CLL and mantle cell today. And so just want to give a quick sort of outline of what is that landscape look like. So here is sort of, NCCN type guidelines for frontline CLL. And if you have a P53 mutation or you don't have a P53 mutation, you can see here more or less the recommendations are the same. They are dominated by novel agents, so acalabrutinib with or without obinutuzumab, then obinutuzumab or single agent zanubrutinib. There are other recommended agents, including ibrutinib-based regimens, but for many reasons, ibrutinib has fallen out of favor in this country for second-generation BTKIs. What do you do then the second or subsequent line of therapy? So again, depending on what you gave in the front line, you're more likely to probably use the opposite agent. So BTK following BCL2 or BCL2 following BTK inhibitor. And then there's some recommendation here for pirtobrutinib if you have intolerance or resistance to prior covalent BTKI. And then what do we do in now the harder place to treat, which is that, sort of dual refractory, your BCL2 inhibitor, BTK, relapse CLL. And so there are options now available, and we'll be covering some of this throughout today's talk with chimeric antigen receptor, CD19 targeted CAR T-cell therapy, and pirtobrutinib, which is a novel non-covalent BTK inhibitor. And there are some other treatment recommendations here. As listed, including PI3 kinases, which also have fallen out of favor largely due to toxicity profile. So how do we sequence care in the modern era? So you can see here that more and more patients are getting targeted therapies in the frontline setting. I think Krish will tell you that probably every patient should be getting those at this point with the data that we have. And sequencing does matter. So how you sequence a patient, so looking at this sort of EHR analysis, those patients who in the relapse setting went from a BTK inhibitor to BCL2 with CD20 antibody had the best overall survival. And so that was better than going from a BTK inhibitor to CD20 alone or going to chemoimmunotherapy. And so this data is very robust, which really tells us that the pathway forward in diseases like CLL is using novel agents and using them in a sequential fashion, again, depending on how they were treated in the frontline setting. And then what about mantle cell lymphoma? Just a quick introduction here. Another disease that has had a very rapidly evolving change in treatment algorithms. For the most part, we look at mantle cell and we sort of divide patients into two groups. Those who are older and non-transplant eligible are often candidates for regimens like bendamustine rituximab, when newly approved regimen of bendamustine rituximab with acalabrutinib. And for younger patients, we gave a high-dose Ara-C-based induction that has been modulated potentially with the triangle regimen, now incorporating a BTK inhibitor as part of the front line. So now in both older MCL and younger MCL, BTK inhibitors are considered a treatment option to give in combination with chemoimmunotherapy as part of that frontline regimen. Transplant remains controversial, although more and more data is suggesting that most patients with mantle cell likely don't benefit from a consolidative transplant, and we'll review that. And then maintenance is given to patients with rituximab with or without a BTK inhibitor. What about the relapse setting? So it all depends, again, how are you sequencing your care? Should they have gotten a BTK inhibitor in the front line? You might be moving on to third line treatments or post-BTK relapse. But for those who are BTK naive, BTK inhibitors are the standard of care in relapsed mantle cell. And you can see here we have acalabrutinib or zanubrutinib. Lenalidomide-based regimens are an option. But when patients sort of fail covalent BTK inhibitors, we are now looking at similar options to CLL of CAR T cell therapy and a non-covalent BTK inhibitor in pirtobrutinib. And so, this is sort of just getting everyone to the same level of where we're starting in mantle cell and CLL. And this is sort of looking at mantle cell outcomes and looking at a patient population who progressed with mantle cell and showing that the time to progression impacts your survival after you progress. So you can see here, what is the overall survival after your first relapse? If your progression of disease happened greater than 24 months, you can see that you had a statistically significantly improved survival, in this population. Whereas if you progressed within 6 months or during your induction therapy, clearly that patient population does really well. So while we have made great improvement in both mantle cell and CLL, there is a population of patients that is difficult to treat and continues to be a challenge. And we hope with new treatment algorithms and new therapy options that we can overcome even some of these more difficult to treat patients. With that, our goals for today are really to improve your knowledge for targeted immune-based therapies in CLL and mantle cell, talking about how to sort of incorporate targeted agents immunotherapy as part of sequential treatment algorithms and disease management, and then provide you guidance on how to deliver safe and effective care with these novel agents and CAR T cell therapy in both CLL and mantle cell. With that, I'm going to hand it off to my colleague, Dr. Patel.
So I'm going to take us through a little bit of a deeper dive into some of the data that has helped us to reshape this standard of care in CLL, with a real focus again on targeted therapies and cellular therapy. All right, so first we're going to talk a little bit about some of the more recent data in frontline therapy and what implication that has for later line care, which is really what we were outlining in some of our polling questions. So as many of you know, we have long had BTK inhibitors available to treat CLL now more than a decade, starting with the use of ibrutinib, and then also venetoclax, which is the approved BCL2 inhibitor that's available to us. But I think we also recognize that there may be some synergy between these agents. So we know that ibrutinib mobilizes CLL cells. We also know that BTK inhibitors as a whole sensitize cells to anti-apoptotic pathways. And so the combination of a BTK inhibitor and ibrutinib is something that we have been studying for some time now, starting with early studies of ibrutinib and venetoclax, with the idea that we may be able to drive some synergy here and really bring the best of both worlds. And so I show you here in just a high-level overview some of the data that has been presented already for the combination of ibrutinib and venetoclax. And what we can see across the board is that in relatively high-risk subgroups, patients who have P53 aberrations, those who have IGHV unmutated, you can see a very high level of progression-free survival using the doublet combination of a BTK inhibitor and venetoclax. And what differs across these trial designs is ultimately the duration of therapy. For example, we may use a completely fixed duration that's agnostic to response, such as was done in the MD Anderson's trial or the Captivate study, or perhaps using an MRD-guided strategy, which is what was done in the FLAIR trial. But I think the point being here is that we can combine these two very active targeting therapies, BTK inhibitors and venetoclax, to achieve deep responses and very durable responses. I think what's probably of more interest to all of us is how do we take that data forward with second-generation BTK inhibitors, those that are more selective, like acalabrutinib and zanubrutinib, as the field has really shifted away from the use of ibrutinib towards more selective covalent BTK inhibitors due to less toxicities associated with these agents. And we recently saw data from the Amplify trial. This was presented at ASH, demonstrating the combination of venetoclax with acalabrutinib. There are 3 arms in this study. The combination of acalabrutinib, venetoclax, and obinutuzumab, the combination of acalabrutinib and venetoclax alone, compared to what was the standard at the time this study was started, chemoimmunotherapy for frontline patients. And what we see here is that both AV-containing arms performed with better efficacy, a superior 36-month progression-free survival compared to the chemoimmunotherapy arm. Now, I'll point out that the study was not powered to look at the difference between AVO and AV, although numerically we see here higher progression-free survival for AVO compared to AV. In terms of safety, I think one of the things that's really important for us to reflect on is that when we use a triplet combination, the AVO combination, there is a cost to be paid for that. And that is mostly borne in the increased rate of neutropenia as well as infections. But I think otherwise, when we look at expected AEs that are associated with the class of either BTK inhibitors or BCL2 antagonists, we didn't see any major surprises. But this may be the biggest difference between these two arms, is the risk of infections does seem to increase with the addition of obinutuzumab. Looking at this in a slightly different way, this is the Sequoia Arm D. This is the Sequoia trial with Arm D highlighted here. This is the combination of zanubrutinib with venetoclax. This was part of the initial Sequoia trial design. And what we see is that the cohort of patients that was studied with this doublet was that population that was P53 aberrant, so a historically high-risk population. And similarly, we can see a very high rate of overall response. Now, the combination of venetoclax and zanubrutinib is not being taken forward. The preferred partner for zanubrutinib is a different BCL2 antagonist. But again, we expect to see similar data or perhaps different data for that combination as well. So the idea here really is that by combining two of our most active targeted agents, we may be able to achieve very good efficacy with a short duration of treatment. And a lot of the studies that are implementing this design of a doublet or triplet-based therapy in CLL are able to mitigate some of the safety risks of the BCL2 antagonist as well by starting with a BTK inhibitor leading. So we can start our patients pretty quickly by giving a covalent BTK inhibitor, a strategy we know to be effective, and then bring in the venetoclax after some time where perhaps the risk of tumor lysis is lessened. And so this strategy has been implemented with all of the covalent BTK inhibitors shown here. So now we're going to kind of turn back to a case to, I think, really delve into some of the questions that these recent disclosures of BTK and BCL2 antagonist doublets or triplets maybe raises. So let's imagine we have a different patient now. This is Susan. Susan is a 69-year-old patient with previously untreated CLL, unmutated IgHV, no P53 aberrancy, bulky adenopathy, well-controlled type 2 diabetes. So this is the same scenario as, Kate, the first question we asked. So I'm going to ask Dr. Shah here to help us kind of think about some of the salient issues. So Nirav, in this type of patient who comes to see you, how do you make the distinction between, say, a continuous BTK inhibitor or time-limited Ven-G? Those are the options we'd had until this point.
Yeah, it's a great question. And I think that, I meet with the patient, so I think a big part of this is patient preference. When it comes to this, I look at the risk features of the disease, and I would say that I'm in the camp where if you did have a P53 aberration or complex cytogenetics, I get worried about fixed duration therapy. And I'm sort of a believer that your first PFS is your best progression-free survival. So those are patients that I may sort of push them towards continuous BTK inhibitor over, the fixed duration doublet. But really, I go through the risk and benefits, and you have to also look at the patient themselves and what are their particular risk features. Do they have a history of atrial fibrillation that may make BTK more challenging? Are they really neutropenic coming into it? In which case, obinutuzumab may be challenging. So it's a bunch of different variables, but I think both are really good options for this patient.
Yeah, I think you said it really well. I mean, until now, it's been this question about continuous therapy versus time limited, and certainly patient preference tends to drive a lot of that. I also share your concerns about Ven-G and P53 aberrant patients, especially knowing how well they do with continuous BTK inhibitors. So thinking about the next question, does the ability to combine a BTK inhibitor and a BCL2 inhibitor really, does that kind of change how you might approach this conversation? You mentioned how it might for the P53 aberrant patient. What about somebody who isn't P53 aberrant?
Yeah, so I think, this data is exciting. It offers patient an oral combination, no IV infusion needed, no infusional reactions, and at least looking at the amplified data, fairly well tolerated, even better tolerated. I think I worry a little bit about triplet in terms of, is too much of a good thing just too much in terms of hurting a patient? And then that's the last thing you want to do in a disease like CLL, where really the name of the game is, to me, is to turn it into a chronic medical condition that can be managed. So I think this offers patients fixed duration therapy that they can get at home.
Yeah, I think you made a great point, which is also that, two oral therapies may actually be much more accessible for some patients, especially those that may live a distance from their treatment center or for whom there are perhaps other challenges that infusional therapy don't allow. We talked about the P53 scenario, and I think here again, the strength of data for BTK inhibitors in that setting might push me to think about that doublet combination if fixed duration is where we want to go. And so, assuming all things are available, how do you think going forward you might be using this? Is this going to be a combination reserved for certain populations, all comers? How does that change for you?
Yeah, so, the trials we have presented don't really compare them to a modern sort of comparator arm, but there are trials being designed right now that I think, I don't know where they are in their accrual, looking at a doublet of AV versus Ven-G. And so I think that those trials will be very telling as to, do we need to give all of our best drugs up front right away? Or is it okay to do Ven-G and then save acalabrutinib, for later lines? And I believe there's similar trials being done with zanubrutinib, with sonrotoclax again versus Ven-G. So I'm sort of looking forward to that data to before I make my final decisions. But I think for anyone who wants a fixed duration oral regimen, should this be approved, the data look good.
Yeah, I think you're right. I mean, the MAGIC trial, which looks at AV versus Ven-G and also uses some assessment of MRD to then answer some other questions, will be a really important study for us. And as I understand, is fully accrued. So hopefully we'll see that data soon. And so just maybe to round out that one question with this case. So let's say we do take a fixed duration approach. We've exposed our patient to a BTK inhibitor and a BCL2 antagonist. How do you think this impacts choices later on, right? Fixed duration, hopefully going to have a good response and a lot of mileage out of it. But inevitably, CLL is a disease we don't cure. So when that patient experiences relapse, how do we approach it then?
Yeah, I think the data we have is limited, right? Because a lot of these patients have done well for a long period of time. Looking at those patients from CLL14 who got retreated with Ven-G, you see or got retreated with Ven after Ven obinutuzumab. They have a fairly good overall response rate. So I think that at the time of relapse, I would then discuss either a fixed duration Murano type treatment of Ven, with the CD20 versus continuous BTKI. I may lean towards BTKI because we sort of failed the fixed duration approach once. But again, part of it also be dependent on how long that first progression-free survival was.
Great point. So lots of different options and more to come there. All right. So in the last few minutes here for the CLL portion, I'm just going to review some of the other options we have here. So while we are thinking about the implications of a doublet in the front line, we also are very blessed to have options today for patients that are exposed to both classes of therapies. And the first one we'll talk about is the non-covalent BTK inhibitor pirtobrutinib. And so pirtobrutinib was really designed to overcome issues of resistance that we know to be important to covalent BTK inhibitors and was studied in the Bruin trial. I'm not going to go through all of the data here, but to suffice to say, when we look at patients who have been exposed to a covalent BTK inhibitor or the combination, maybe sequentially, of a BTK inhibitor and a BCL2 inhibitor, we see very high rates of response with pirtobrutinib and the potential for durable PFS. Now, I will note that many of the patients on Bruin who enrolled in this study had many lines of prior therapy. So a lot of these patients probably also had exposure to chemoimmunotherapy. So when we look at the PFS, that's important to note. We also saw an update at this year's ASH of a randomized study of pirtobrutinib, comparing pirtobrutinib to investigators' choice of either idelalisib, rituximab, or BR. So this study, Bruin 321, shown here, essentially demonstrated, perhaps no surprise, that pirtobrutinib was superior to the IC combination. When we look at the IC arm, the majority of patients received idelalisib and rituximab, and more than half of the patients in this study had received prior venetoclax. And then I'll just point out, when we think about factors that tend to be enriched in the relapse setting, complex karyotype, P53 abnormalities, that was represented certainly in both arms. So here's the PFS curve for the study. The study was positive in favor of pirtobrutinib. You see this early separation of the curves that's maintained over time. The median progression-free survival for pirtobrutinib in this setting, again, late-line patients, median prior lines of 3 was 14 months compared to 8.7 in the investigator's choice arm. And if we look at time to next treatment, right, I think a very clinically functional endpoint for patients, time to next treatment, the median time to next treatment was 24 months or 2 years in patients receiving the pirtobrutinib, slightly higher if the patients had not previously had venetoclax. Across all subgroups, it appeared that the benefit was consistent in favor of pirtobrutinib, in particular those patients that had p53 aberrations, complex karyotype, or were unmutated. And so pirtobrutinib represents, I think, a very appropriate option for patients who have been exposed to a BTK inhibitor and potentially also a BCL2 inhibitor in that setting. But we have another option in this setting as well, which is lisocabtagene maraleucel, a CD19-directed CAR T-cell therapy. And here shown is the study schema for the Transcend CLL-004 trial. This has been presented several times, so I'll just highlight some of the key factors of this study. These patients were quite late line. So at the time the study was ongoing, you see the key eligibility here, and that's reflected in the data set. The overall study was the overall response rate was just a little bit under 50%, and we see that around about 18% of patients had a complete response rate. Remember, it's very hard to achieve a complete response rate in CLL, and so in the context of other therapies we have, I think while that number may look in absolute terms small, it's quite impressive. And then when we look at the outcomes for patients who were able to achieve that depth of response, you can see that represented in the blue line here with the progression-free survival, the median not yet reached. Even for the patients who achieved a partial response, you see this PFS again in that about a little more than 2-year range, 26.2 months. And while we don't show it here, we can also use measurable residual disease to help further kind of stratify outcomes. So patients who achieve UMRD in particular have very good outcomes, whether they have CRs or PRs. And so this has led to the availability and the approval of liso-cel for patients who have received 2 prior lines of therapy, which included a BTK inhibitor and a BCL2 antagonist. Combinations of liso-cel have also been studied. There may be some immunomodulatory properties of drugs that we want to capture in the run-up to CAR T-cell therapy, and that's been studied in a combination with ibrutinib. And I'm just going to point this out here as a signal where in that cohort, we did see a higher CR rate, almost double, suggesting again that the fitness and the health of T cells as we go into the CAR T experience may be important, and exposure to certain drugs, including BTK inhibitors, might actually be beneficial in that setting, even if patients have clinically progressed on those drugs. So when we think about in practice, these are our considerations for patients today who have had a prior covalent BTK inhibitor and also have had a prior BCL2 antagonist. We are often thinking about 2 very different modalities of treatment. Pirtobrutinib is a very safe drug, usually accessible to most. CAR T-cell therapy, perhaps maybe we have some more limitations there in terms of fitness of the patient, the support the patient has, but can be a very reasonable option as well. And importantly, we recognize that high-grade acute toxicities do occur in patients treated with CLL with CAR T-cell therapies, including around 10% grade 3 or higher CRS and about 18% grade 3 ICANS. So this is important in patient selection. So as we just kind of round out, and I'm going to go through this last case a little bit quicker here, we have a patient, 73 years old, performance status is 2, is declining with relapse refractory CLL, has had ibrutinib before, had Ven-G, but progressed relatively quickly after stopping Ven-G. And we have a different scenario for the same patient. Let's say the patient's performance status is better. So, Dr. Shah, in this setting, how do you decide between non-covalent BTK inhibitor and CAR T-cell therapy?
Well, I think the story's in red right here, right? I mean, we're talking about an oral pill with an impeccable safety profile in pirtobrutinib, really few off-target toxicities, and patients can do well on it. A declining PS of 2 with liso-cel that does have grade 3 or higher CRS and ICANS, I'm going to lean towards pirtobrutinib and sort of, maybe actually the drug improves its PS because some of this is related to disease. In the counter patient here, I might do what the audience here said of use pirtobrutinib as a bridge, see how they're responding and sort of get their disease into a good controlled state. to minimize the risk of CAR T.
Yeah, I think you said it really well. We have to be really thoughtful about functional status, the support the patient has. And I would say, age is not a limiting factor, but we have to be really intentional about how we take that patient to CAR T cell therapy. So perhaps trying to cool them off with the pirtobrutinib and doing so can be helpful. And then here we have a couple of follow-up questions, but I'm just really going to ask you to pick one. Are there biomarkers that maybe help us in selecting a patient? Let's say, is testing for BTK mutations helpful? Does that ever inform your decision towards, say, something like CAR T?
And unfortunately, I think that a lot of this stuff is exciting to do in the setting of a clinical trial. How do we make pragmatic decisions based on this finding? I think is a little bit less clear. To me, if they're clinically responding, they're responding. And if they're in, a clinical response, they're in a clinical response. And I have not yet used these endpoints to make decisions.
Great. Thank you. All right. With that, I will turn it back over to Dr. Shah. Thank you.
Thank you, Krish. Always enjoy hearing you talk about CLL. We're going to go down a different route here and talk about MCL, which has a lot of similarities to CLL, but clearly different treatment algorithms. So let's go through the data here. Talking about stem cell transplant, we are at the Tandem meeting, so I think really important to highlight the role of transplant, which has been the mainstay of how we have handled younger, fitter mantle cell lymphoma for 20 plus years. But there's been two large data sets that have clearly challenged the role of autologous stem cell transplant consolidation in the frontline setting. I think almost everybody here has at least heard of the Triangle study. This is a 3-arm clinical trial where patients were sort of given a standard of care arm with a cytarabine-based induction, followed by autologous transplant, followed by arm maintenance, although that was sort of modified about halfway through the trial, compared to 2 other arms, one which included ibrutinib as part of induction and maintenance, but maintained the role of autologous transplant, and one that did ibrutinib as part of induction and maintenance, but removed autologous transplant. And what you can see here is that this has sort of been fully reported. They're now long-term data sets that continue to come out. But you can see here that stem cell transplant with ibrutinib was superior in terms of outcomes to autologous transplant alone, a 3-year freedom-free survival of 88% versus 72%, and that autologous transplant alone was not superior to ibrutinib without the autologous transplant here. And you can see here that the 3-year freedom-free survival, again, for the autologous transplant was inferior to those patients who didn't even get an auto transplant, but got ibrutinib as part of induction and maintenance. Finally, comparing those 2 arms where both got ibrutinib, longer follow-up is clearly needed. The 4-year freedom-free survival is very similar at 82% versus 81%. But the takeaway here is by adding a BTK as part of induction and maintenance, that we are overcoming some group of patients with mantle cell that clearly were not doing as well without getting that agent as part of the frontline and maintenance strategy. This was updated data presented at ASH that sort of tried to tease out, are there some groups of patients here that maybe did a little bit better if they did get the autologous transplant? And so they sort of separated this by risk profile. Ki-67 is a biomarker for aggressiveness in mantle cell lymphoma. And for patients who were less than 50%, you can see here, whether or not you got a transplant, the freedom-free survival is relatively overlapping. But in that subgroup of patients, and again, we have to be careful with subgroups because we're teasing out smaller numbers of patients, there is potentially some benefit here to autologous stem cell transplant in that higher risk profile patient population. Well, what else came out about transplant? So another very large and important study was done here in the United States now, unlike the Triangle study. This is the ECOG Akron 4151 clinical trial that has been ongoing for nearly a decade and enrolled over 600 patients. And this trial was actually trying to use novel biomarkers to determine, is there a subgroup of patients that actually benefits from transplant? So I want to go through the study schema here very quickly because it's important to understand how this was done. The key thing is they were using MRD as a major endpoint for decision making. And so they had to obviously assess whether you had a clone that could be followed. If you did, and you were MRD negative, those patients were the primary analysis for this study, and they were randomized to getting an auto transplant with 3 years of rituximab maintenance or no auto transplant and just rituximab maintenance. For those patients who were MRD positive because it was unclear, they were recommended to get an autologous transplant and maintenance therapy. And those that didn't have a clone, again, were recommended to get an auto transplant and rituximab maintenance. This was a late breaker at the ASH meeting, and you can see here sort of the collated results. And if you look at these differences, so focusing on arm A and B, these are your MRD negative patients. There's no difference in overall survival or progression-free survival. So if you're MRD negative, whether you got an auto transplant or not, if you got 3 years of rituximab maintenance, you can see that the curves are overlapping. And this was true even if patients, the first is looking at all randomized, the other one is looking at treated as assigned because some patients opted to do an auto transplant even if they were recommended not to do it, or chose to opt out of an autologous transplant and did maintenance. So regardless of which patient population you look at, no difference in overall survival or progression-free survival. And that's why the study was ultimately stopped when they hit that endpoint and saw there's no likelihood of an overall survival benefit developing with further follow-up. The interesting thing again is here we're looking at the MRD positive patients. So again, perhaps a signal here that there's a subgroup of patients that could benefit from autologous transplant. Those patients who converted to MRD negative, meaning the auto transplant perhaps helped that conversion, had a sort of 100% progression-free survival or overall survival. And you can see here, it looks to have a better progression-free survival as well. And so, while auto transplant is likely going to fall out of the mainstream for every single upcoming mantle cell, some of the data we see here shows that there might be subgroups, MRD positive, Ki67 high, that still may have some benefit from auto transplant. In the older, unfit patients where auto transplant was never part of our treatment algorithms, we often use chemoimmunotherapy regimens such as bendamustine rituximab. And so here is sort of the data from the ECHO clinical trial, which was acalabrutinib with bendamustine rituximab with acalabrutinib sort of maintenance, followed by against placebo and bendamustine rituxan. And so this demonstrated that there was actually a progression-free survival benefit with the triplet combination. And then if you sort of censored out COVID-19 deaths, which was a problem during this time period, that actually was a more significant benefit in those patients getting the acalabrutinib. And this data actually led to the very recent approval of this arm of this triplet combination, again, in the transplant ineligible patient population. This again is looking at MRD, so looking at biomarkers to see, does adding acalabrutinib deepen the response? So you can see here that, not only does it deepen the response and that you have higher rates of MRD negative patients, you also have less patients converting to MRD positive and more patients converting to MRD negative with the triplet combination followed with single agent acalabrutinib. Now, the counter whenever we add drugs to the regimen is always going to be toxicity, as Dr. Patel talked about, using a triplet versus a doublet. Here, fortunately, the overall incidence of adverse events was relatively similar. You can see here sort of higher grade, it's actually similar rates of grade 3 and 5 toxicities, regardless of which arm these patients are on. And so being a second generation BTK inhibitor, again, more tolerable, safer, you see those outcomes playing out here as part of a clinical trial. Enrich was a clinical trial done in the UK. And then this is now looking at patients who got our chemo-based therapy, an older patient population, so less fit perhaps, 60 and over with a treatment sort of untreated mantle cell lymphoma here, and they got either ibrutinib rituximab or our chemotherapy. And so here again, we see that a novel agent with rituximab here has an improved progression-free survival compared to standard immunochemotherapy. So more data, again, suggesting the role of BTK inhibitors in the frontline setting, here again in an older patient population. This is looking at some of the future regimens that are being developed, and there's now triplets being developed in mantle cell lymphoma as well. So what happens in CLL slowly often follows in the world of mantle cell lymphoma. And you can see here that this triplet from OASIS, where you use ibrutinib with CD20 antibody and venetoclax, leads to high rates of MRD negativity. And again, we believe that MRD negativity may not correlate with cure, but does correlate with a durable progression-free survival, a durable response. And so there's lots of other clinical trials going on using novel agents such as zanubrutinib, acalabrutinib with rituximab in the Mangrove study, and triplets, also including bovin, which has been studied in a high P53 enriched patient population and looks to be very effective in even some of the most difficult to treat mantle cell lymphoma patients. So we're going to have a case here, and I'm going to lean on you, Chris, here to sort of help us work through this. We have Mark here, who's a 62-year-old patient, stage 4 mantle cell, Ki67 30%, PS of 1, and no TP53 mutation. He's eligible for a chemoimmunotherapy induction, but he's not sure if he wants to transplant. So I guess, there's some questions here, but are you offering a BTK-based induction? And what are you telling him about transplant based on the data that I just shared?
Yeah, no, great question. I think maybe the transplant one is perhaps easier to start with. I think for a patient like him who has classic mantle cell, there probably isn't going to be a lot of benefit to transplant, albeit one could argue kind of need to see what his response to initial therapy is. And I would probably talk to this patient mostly about bendamustine-based therapy plus minus acalabrutinib. I think the advantage for somebody of the triplet is that, it gives them some potential longevity in that first therapy. They don't have to think about, relapse and hopefully until a later time point. But I guess the question in my mind is really, do we get more out of the triplet versus sequence, right? And to maybe use the BTK at relapse. So I like to try to involve the patient in that discussion. And if they achieve a deep response, probably unlikely to go transplant.
And then are you, here in the United States, the ibrutinib's label for mantle cell has actually been voluntarily withdrawn. So how do you apply Triangle? Are you just sort of substituting in second generation BTK inhibitors, and are you comfortable doing that?
Yeah, I think for somebody who is younger, where, the incorporation of the cytarabine-based regimen, I think we have other data with second-generation BTK inhibitors like acalabrutinib, where I think that question for a younger patient becomes even more important, right? The long-term plan. And I think there, the data is quite impressive. We saw a recent update as well, and I think I would offer that patient the incorporation of the BTK inhibitor if they're getting cytarabine-based induction.
Yeah, I agree with you, with almost everything you said. And I think the one thing that I'm going to start thinking about doing is, with the data from ECOG, is getting an MRD at the end of treatment, right? It's the first time decision making actually happened based on MRD status. And then if you're negative, I think it's a very clear discussion that, really no role for autologous transplant. And if you're MRD positive, then maybe I'm giving ibrutinib or acalabrutinib maintenance with rituximab to overcome some of those, deleterious findings. And then here we're going to change Mark's situation very briefly. Performance score is now 2, and he's uncertain about CIT and pursuing stem cell transplant. So are you good with chemo-free?
Yeah, I mean, this is a tough one because I think you're always thinking about the long term for these patients, right? And you wonder, is the PS2, like you said earlier, really disease related and that could get better with therapy? But assuming that chemo is just not a go, I think here we have smaller data sets with the combination of BTK inhibitors and rituximab. They do look quite good. They're very, very active. My hope would be that, we'll see a lot of durability with those, but the follow-up is relatively short to this point. But they're very active, and I think if you have a patient that absolutely can't get chemo, that's...
And there's trials. They're going to help answer this. Zanubrutinib rituximab versus bendamustine rituximab is going to really help us tackle some of these questions about how efficacious these regimens are. Moving on now to relapsed refractory mantle cell lymphoma. So we're going down a similar paradigm. So pirtobrutinib was studied as part of the Bruin clinical trial in multiple histologies. Other than CLL, there was a lot of data in mantle cell lymphoma. And so this is looking at a patient population who have had prior exposure to covalent BTK inhibitors and came off of it either due to progression or due to toxicity or intolerance. And you can see here that despite that, a waterfall plot that looks beautiful for pirtobrutinib, again, there's some patients that were non-responders, but an overall response rate of 50% and a CR rate of 16%. I'm going to go through this very quickly here just because we're a little bit short on time. But, looking at a subgroup analysis here, there aren't large differences except when you get to the bottom here. So those patients who discontinued the BTKI due to true progression sort of had an overall response rate of 43%, whereas if you came off to the BTK inhibitor due to toxicity, meaning you were still BTK sensitive, you see an overall response rate of 91%. What is the progression-free survival? So the median progression-free survival for covalent BTK-treated mantle cell was 5.6 months, but the median overall survival was 24 months. And I think that's a good surrogate of how effective this drug is. We know that those patients that fail covalent BTK inhibitors is often like falling off a cliff. And so disease stability with pirtobrutinib was actually something that we saw in the clinical trial. The data for this drug were compelling enough that it led to the development of this very large phase 3 clinical trial called BRUIN MCL, and this is going to help us make that decision. Is a non-covalent BTK inhibitor potentially a better therapeutic option as a first BTK inhibitor to give to patients with relapsed mantle? So randomized controlled trial, one arm got pirtobrutinib, the other arm was dealer's choice. So it's not a blinded study, but the investigator got to choose between ibrutinib, acalabrutinib, and zanubrutinib. It's a global study, so those in Europe probably got ibrutinib. Here in the U.S., most patients got acalabrutinib or zanubrutinib. This study is completely accrued, and we look forward to seeing results from this in the near future. CAR-T is the other major player in mantle cell lymphoma, and it is really a therapy that has incredibly high efficacy, but it comes again with some degree of risk. So here you can see here that with brexacaptagene autoleucel, you get an overall response rate of 90+%, 12-month progression-free survival was 75% for all patients and higher for those in CR. But the hard part here is the grade 3 or higher toxicities, neurological events of 27% and 21%, grade 3 or higher CRS, meaning you're on pressors, of 6%. Lysocell is a different CD19 CAR T cell product. It has a different co-stimulatory domain. And with that, it has a different sort of safety profile. Here, you can see here the overall response rate's a little bit lower at 83%. The median progression-free survival was similarly a little bit lower at 15 months. But from a safety standpoint, you see here grade 3 to 4 cytokine release syndrome, the grade we care about, of 1%, neurotoxicity of 9% grade 3 or higher, so substantially lower than we saw with the other clinical trial. And then finally, bispecifics are gaining a lot of steam in mantle cell lymphoma. Glofitamab is a CD20 by CD3 bispecific with a 2-to-1 binding on the CD20. And here they took a patient population, relapsed refractory mantle cell, many who had prior BTK, and you can see here really a high complete response rate of 71% if you had prior BTK, higher if you were not BTK exposed, and a 15-month progression-free survival of 54%. There's an ongoing phase 3 clinical trial, hopefully that will lead to the approval of this drug in relapsed refractory mantle. So, really quickly, I'm just going to go through these two quick cases with you, Krish. We have two patients here. One's 75, one is 60. 75-year-old has sort of indolently mantle cell, got chemoimmunotherapy, got 2 years of covalent, got a long remission, and has a performance score of 2, but 75. We have a younger woman here, high Ki67, high blastoid disease, got second-line acalabrutinib, and progressed in 13 months. What are you doing for these two patients?
Yeah, so two very different patients. I mean, I think the first patient biologically appears to be somewhat standard risk, has had, good responses to initial therapies and the covalent BTK inhibitor. This is the patient where I think pirtobrutinib really makes a lot of sense. It's very difficult to take a patient who has poor performance status through the CAR-T. I think of all the B-cell lymphomas, the toxicity for high-grade toxicities, ICANS and CRS is highest in mantle cell. And so I think that patient is a great pirtobrutinib candidate. The second one, I think, the things that really stand out are high Ki67 and blastoid disease. P53 aberrations are very common in blastoid disease. These patients often have very short responses to single agent therapies. And this is the patient, I think, where CAR T cell therapy provides hopefully the best durability, albeit that isn't perfect either.
Agree. And I think I would do basically the same thing as you in both of these scenarios here, which are tilted towards one treatment or the other, but shows the variability that we see when we deal with mantle cell patients. And so, I think a lot of this discussion here is what we talked about already. What could we have done differently? I think the key thing with any CAR T, and we're at a transplant meeting, so a lot of you do CAR T, but the message to the community I've always given is let them meet a CAR T specialist so the decision can happen with that doctor. I think Lysocell opened the door for patients that I wasn't comfortable giving Brexacell to. And so we do have different options available. And so it's at least good to have the discussion, even if the ultimate decision is to go with pirtobrutinib. So as we wrap up mantle cell, again, we're seeing evolving treatment algorithms. I think we're going to see a shift of more and more novel doublets and triplets happening in the frontline setting, which all these shifts are third line therapies such as pirtobrutinib and CAR T into the second line, with bispecifics then being potentially a third line treatment. But as you guys know, and why we come to these meetings is to try to stay up to date with the rapidly evolving field of treatment algorithms in both CLL and mantle cell. We have a few minutes left, and many of you did write wonderful questions here. So I'm going to play a little game with Krish here, and we're going to sort of try to handle these one by one. And if you have other questions, you're also welcome to come to the microphone. So, why don't you take the first one, Krish? Any data on bridging with pirtobrutinib to CAR T in mantle cell? Have you done it? Is there data?
Yeah, definitely done it. And I would say that there isn't data per se on outcomes like for that combination, but many of the patients that we see in practice are likely going to go through that route. And so I think it'd be a really interesting question for kind of real world evidence study.
Yeah, I'll tell you that our group at the medical college, and Dr. Patel knows about it, we had a poster at ASCO where we looked at patients who got pirtobrutinib directly before CAR T cell therapy and actually saw a promising signal and saw some benefit in the T cell fitness. We actually have developed an IIT to help answer this question. It's actually using pirtobrutinib followed by a dual targeted CAR, followed by pirtobrutinib maintenance. And we just activated and enrolled our first patients. So we look forward to sharing that. Next question here. This is, again, another bridging question. When using a bridging option prior to CAR T, assuming you were using a continuous BTK inhibitor, would a high quality response make you defer CAR T? I can handle, I'll take this one. It's a great question. So you start pirtobrutinib and they get into a beautiful response. Um, I would struggle with that decision making because you have a treatment that's very well tolerated, and there is a group of patients that gets 2 to 3 years right on pirtobrutinib, and now we have degraders coming and bispecifics, and so I would say that it's a conversation with the patient. I would really look at their age, their longevity, their comorbidities into sort of making that treatment decision, for the patient. Anything to add?
Yeah, I would just maybe add, I think it's different in MCL than it is in CLL, where the duration of response is going to be much shorter with Pirto. And that patient, I probably would still try to line up for CAR. And you don't have to give the CAR, right? That's one of the advantages. You can continue to see the response.
Yeah, it's a good point about mantle cell, and I do agree with you there. All right, Krish. So I talked about the ECOG Akron data and gave my viewpoint. So, but what is your take on the ECOG Akron data? Does it mean we should reserve transplant for the highest risk scenarios?
Yeah, I think it's a lot to unpack, but I think Triangle plus the ECOG data for me says that, probably for the small subset of patients who are MRD positive and have high risk features, those are probably the patients I would consider for a transplant.
So the vast majority of your mantle cell patients are not getting an auto transplant in 2025. Okay. Here's another stem cell transplant question. Any role for stem cell in later line mantle cell lymphoma care? Someone who's obtained a good remission to covalent and non-covalent BTK inhibitors, for example. So, wow, we're entering data-free zone here. So there was one study going back from the CIBMTR that actually looked at early transplant in mantle cell versus later transplant in mantle cell, but that was in a pre-novel agent era, and it said that early transplant was better. Here now in the later setting, I think it's going to be very difficult to use an auto transplant because our treatment algorithms would be involving things like CAR T cell therapy, BTK inhibitors, potentially venetoclax. And I think that those patients would not do well with an autologous stem cell transplant, sort of regardless. And I don't know what you do, Krish, but post CAR relapsing mantle, if we are able to get him into remission, we consider an allogeneic transplant. Um, you know,
Yeah, exactly the same. I think no role for auto in that.
I thought there was someone at the microphone, but perhaps he stepped down. Okay, all right. Sorry about that. Well, we have plenty of questions here to continue with, and we have still several minutes left. Um, this is a great question, actually, Christian. Why don't I have you handle this one? Have you ever considered CAR T for an MCL patient early in chemoimmunotherapy, high risk features P53, either as consolidation or in the early relapse setting?
Yeah, so certainly yes. The initial label for Brexacel was quite open, right? Relapse refractory. And so I think, patients who historically have very short duration of response to covalent BTK inhibitors include those who have P53 aberrations in particular, or blastoid morphology. So for those patients, if you are fortunate enough to be able to time the delivery of the CAR T cell as a second line therapy, I think that makes sense. In reality, a lot of times you're giving the patient a BTK inhibitor while you're getting them to the CAR T cell, but I think those high risk patients certainly can be treated with CAR T cell early.
Yeah, I mean, the patients that I've struggled with the most are those, right? They're progressing after cycle 6. Those aren't people that I think are going to get a durable response to BTK. So I think similar to you, it's a bridge to an early CAR T cell therapy. Would you consider ABR, so I'm assuming this is acalabrutinib bendamustine rituximab, for borderline MCL cases where transplant was possible, but you're sort of unsure about the benefit in that situation? So I think that the data we show actually suggests that incorporating BTK inhibitors from the Triangle study from ECHO may actually sort of eliminate the need for auto transplant. And in a borderline patient, with the data we have, and knowing that auto transplant is toxic, we didn't go over that data from Triangle and ECOG, but secondary malignancies, treatment-related complications, cytopenias, I think is fair game to say that instead of an auto transplant, we're going to give a BTK. What do you think?
Yeah, I would tend to agree. I mean, I think all of the incorporation data suggests that there's a benefit in all those settings.
Great. All right. So I think we have time for 2 more questions because we have 2 minutes left here on our clock. And thank you again. I hope this was useful to all of you here today. This is a good question. These are great questions. Any role left for allogeneic stem cell transplant in CLL, or has it been completely eclipsed by targeted agents in CAR T? Same questions for chemoimmunotherapy.
Yeah, that's a really tough one. I mean, I think we can't forget that, patients historically have been able to achieve curative outcomes. I do think what you mentioned in terms of what is coming, what is available at many centers, beyond CAR T and beyond non-covalent BTK inhibitors, degraders, novel BCL2 antagonists, novel cellular therapies, that it's getting harder and harder to define who that may benefit, but there may be a very small subset of patients who are so-called, pentarefractory CLL, who have had all of those therapies, for whom if you can get them into a good enough response, and they're fit and they have a good donor, that may be an option, but I think it's a really small.
Yeah, I completely agree with you, but you see the zebra sometime, and I had a 25-year-old with CLL who blew through FCR, ibrutinib, venetoclax, has gotten CAR T, and we're actually is in an MRD negative remission at 33, but I'm not even sure at 33 if he's going to be cured with the CAR T, and we've actually hemmed and hawed about a consolidative transplant. You, my friend, could have the last question on the stage here.
There's conflicting reports about whether bispecific antibodies for CD20 cause exhaustion and change the phenotype of the cells. So my question is, um, then there was the European data that said that if you can bridge to CAR T cell, do you have any personal information that could add insight to this? Because it seems like 2 mutually exclusive concepts with not enough data.
Yeah, I think it's a great question, Mark. I think one of the struggles we have is difference in the duration of exposure and the frequency. I think that's probably important. If there's anything to be learned from the ALL experience, it's that continuous repetitive exposure probably does lead to T cell exhaustion. We have different dosing paradigms for different agents in a lymphoma. So that maybe that accounts for the discrepancies, but I think it's an open-ended question.
Yeah, I mean, I struggle with this. I mean, I think that, in a lot of lymphomas where we use CAR T, we think of it as a curative intent treatment, at least in DLBCL. So I have not been on the camp of early bispecifics because we just don't know how it works and whether or not that diminishes efficacy. But I think it's going to be an area where data is going to grow because they're moving up in the front line, whether we like it or not. And so we're going to see what happens to the T cells in those patients who progress after getting early bispecifics. With that, thank you guys so much. You're an engaged audience. I hope this was useful, fun for me. Nice to work with you, Krish.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, Peerview Institute for Medical Education. This activity is supported through independent educational grants from AstraZeneca, Bristol-Myers Squibb, and Lilly. To access all materials for this activity, visit peerview.com/FFD860.